Hello, my name is Caitlin McGuire, and I am a second-year student in the Master's in Athletic Training program here at Merrimack. This presentation is a poster on synthetic mesh used to repair quadriceps tendon rupture. So to start, what is a quadriceps tendon rupture? So your quadriceps muscle is on the front of your thigh, and the tendon extends just over your knee, right to the bottom of it. So a quadriceps tendon rupture is an uncommon injury, but has serious functional consequences when it does occur. Following total knee replacement, extensor mechanism insufficiency is rare, but a debilitating complication. Direct tears typically occur to the quadriceps tendon on the superior pole of the patella. There is most often a palpable defect in the muscle corresponding with extensor lag. The medial and lateral retinacular are also usually disrupted during this injury. What are current surgical repair techniques for this injury? Quadriceps tendon ruptures usually require surgical intervention, and methods of repair include primary repair and the use of rotational muscle flaps, Achilles tendon allografts, and whole extensor mechanism allografts. Poor outcomes have been shown with primary repair, and the results of allograft reconstruction using Achilles tendon bone block or whole extensor mechanism allograft have been variable, with high rates of prosthetic joint infection and progressive tissue elongation resulting in late extensor lag. Because of this, a synthetic mesh allograft has been introduced and there have been promising outcomes. So what is this synthetic mesh and how is this procedure performed? A mesh consisting of synthetic knitted myofilament polypropylene heavyweight mesh, also known as Marlux mesh, has been used for repair of the quadriceps tendon rupture. Use of this repair may allow earlier range of motion and functional restoration of extension, especially in patients with diminished tissue quality or increased demand on the repair. Complication rates and failure rates appear to be lower with mesh compared with allograft reconstruction. Synthetic mesh repair is also more cost-effective compared with other surgical techniques. A 10 by 14 piece of mesh is rolled into a tube approximately 8 to 10 layers thick. This is then tunneled through the mid-substance of the quadriceps tendon and secured with multiple number 5 and number 1 non-absorbent sutures. A tunnel is prepared distally over the patella, covering the graft and host tissue. The mesh is then drawn distally to the insertion of the patella tendon and secured distally with number 5 and number 1 sutures. What is the theoretical basis behind the synthetic mesh repair method? One study assessed the retrieval analysis of a failed polypropylene mesh graft used for extensor mechanism reconstruction after total knee replacement. Gross analysis of this graft showed excellent incorporation into the host tissue. Histologic analysis revealed surrounding fibrosis with foreign body giant cell reaction and without significant acute or chronic inflammation. The abundant and robust fibrous tissue infiltration with soft tissue incorporation confirms the theoretical basis for this technique and supports the continued off-label use of this procedure. Are there any specific surgical techniques that have been found to be more effective or less effective? When performing mesh-augmented extensor mechanism repairs, it's important to advance the vastus medialis to cover the mesh with host tissue, both proximally and distally. The advancement of the vastus medialis over the mesh is referred to as the pants over vest fashion. It is also recommended to secure the mesh distally into an intramedullary trough in the tibia using cement. This method has been shown to result in robust fixation of the graft, and failure at this interface has not been reported. Suturing the graft into the soft tissues or securing it into the tibia in an extramedullary position may increase the chance of failure. In one case of failed synthetic mesh after total knee replacement, the mesh graft was attached medial to the patella over the parapatellar arthrotomy closure. It is proposed that this led to the graft displacing the patella and resulted in patellar dislocation and further revision surgery. As seen in this case, surgical technique is important, and failure of the reconstruction may be due to technical aspects and not the physical mesh itself. How does the prognosis of this technique differ between surgical techniques? Multiple studies have demonstrated inconsistent results of a host of surgical repair and reconstructive techniques, including primary repair and the use of rotational muscle flaps, Achilles tendon allografts, and whole extensor mechanism allografts. High rates of mechanical failure, infection, and unsatisfactory clinical outcomes have been demonstrated with the use of Achilles tendon allograft. Reconstruction with the use of extensor mechanism allograft has been associated with complications, including symptomatic lengthening at midterm follow-up. Although pain may improve following various reconstructive techniques, many patients struggle to return to their pre-disruption functional capacity and range of motion. Synthetic mesh has been found to have excellent survivorship among patients with patellar or quadriceps tendon rupture or patellar fracture in the setting of acute, subacute, or chronic extensor mechanism disruption. Using this repair may allow earlier range of motion and functional restoration of extension, especially in patients with diminished tissue quality or increased demand of repair. The use of synthetic mesh avoids donor site morbidity, which is associated with autograft augmentation of repair. What does the rehab protocol look like in the literature? I investigated several different studies that had different rehab protocols, and they are as following. Wood et al. Compared outcomes of synthetic mesh repair and allograft repair and used a rehab protocol that consisted of keeping the knee in full extension for a minimum of 6 weeks, 2 to 3 months in patients with previously failed reconstruction or long-standing chronic disruption, and a locked hinge brace or a long leg cast. Progressive range of motion and active assisted extension occurred over the next 6 weeks. Mori et al. Looked at synthetic mesh augmentation and maintained patients in a bulky post-operative dressing for 24 to 48 hours after surgery. Patients were then transitioned to a hinge brace with flexion set to intraoperative findings. Partial weight bearing with gait aids was recommended for 6 weeks, and after 6 weeks, patients were allowed to return to weight bearing as tolerated. Patients were instructed in isometric quadriceps strengthening and range of motion exercises. Bateman et al. Used a post-operative rehab protocol that included 8 weeks of long leg cast immobilization and full extension with isometric quadriceps exercises. Progressive knee flexion was then initiated in the hinge knee brace, allowing 0 to 30 degrees for 4 weeks and achieving 90 degrees during a 4-month period. Abdel et al. Studied Marlex mesh, and the rehab protocol consisted of a long leg cast that included the foot that was applied to all patients, with the knee in full extension for 12 weeks. The cast was typically changed every 2 to 3 weeks to prevent any pressure ulcers. During this period, patients were toe-touch weight-bearing and remained on anticoagulants. At 12 weeks, patients began a partial progressive weight-bearing protocol that included the use of a hinged knee brace, locked in extension at all times while walking. Therapy was initiated at this point as well, with 0 to 45 degrees of motion allowed the first month, 0 to 60 degrees the second month, and 0 to 75 degrees the third month, and 0 to 90 degrees the fourth month. Thereafter, patients could weight bear as tolerated without any limitations of motion. Patients were recommended to continue the use of a cane to avoid any catastrophic falls. Lastly, Farag et al. Used a rehab protocol where patients were placed in a long leg cast for 10 to 12 weeks. After that, they were treated with a hinged knee brace and partial weight bearing for additional 16 weeks. The specific protocol included flexion from 0 to 45 degrees at the first month, 0 degrees to 60 degrees for the second month, 0 to 75 degrees for the third month, and 0 to 90 degrees for the fourth month. The knee was locked in extension at all times when ambulating during this progressive period. Lastly, in this procedures box, there are some nice images that show how the procedure is performed. So in the box on the top right corner, you can see an image of what the mesh looks like itself. And then over here, so figure 1 shows a typical direct tear of the quadriceps tendon from that superior pole of the patella. You can see the defect there. Figure 2 shows the first step in the reconstruction is creating an intrasubstance tendon portal that allows a passage of the graft. Figure 3 shows the rolled synthetic mesh being passed through this tendon portal. Figure 4 shows the synthetic mesh being sutured to the host tendon with multiple number 5 non-adsorbent sutures. Figure 5 shows a ventral patellar tunnel being created. Figure 6 shows the synthetic mesh being passed distally through the patellar tissue tunnel. And Figure 7 shows the synthetic mesh graft finally being tension and secured with multiple number 5 and number 1 non-absorbent sutures. Thank you again.